Getting ready for the RNC, NIC, or CCRN exams? We've got the perfect tool to help you succeed, the all-new Power Pack. It's designed with busy nurses in mind, featuring an easy-to-follow exam prep module, over 200 flashcards to boost your recall, and a practice exam to track your progress. Plus, you'll earn 6.5 CE credits along the way. It's also mobile-friendly and aligned with the NCC Candidate Guide, so you can study whenever and wherever it works for you. Visit iLearn today to take the next step towards your certification. Hello, and welcome to NANCast. I'm Jill, your host. Rounds. It's probably everyone's least favorite time of day, a time of stress and anxiety, but they are so important to the patient's care. Ideally, rounds should be efficient, satisfy the needs of all disciplines, and result in optimal care plans with the patient's family contributing to the plan. Unfortunately, they can be challenging due to the medical complexities of NICU patients, high workload, and the need for effective communications with parents and the healthcare team. How can we, as NICU nurses and APRNs, improve rounds? And how do we ensure parents feel informed, empowered, and included in their baby's care? Today, we're diving into an incredible project that's transforming the way families and care teams connect during rounds. Joining us are Dr. Michael Pitt, a dedicated pediatrician whose primary focus of improving the way medical providers communicate with each other and their patients, and Ryan McQuillan, a NICU dad of twins who knows firsthand the challenges families face in staying involved in their baby's care. Together, they've been part of an initiative that has reimagined communication in the NICU, introducing Q Rounds, a virtual rounding queue software that ensures families and the healthcare team are always in the loop. We will hear about their journey of creating the pilot study for Q Rounds, the impact it's having on patient care, and what this means for the future of neonatal medicine. But beyond this technology, today's conversation is about better communication with families in the NICU. Let's get right into it. Thank you for joining us today. So rounding doesn't get the best rap. I think there's a lot of negativity amongst all healthcare providers on rounding, whether you're the medical team, the nursing staff, respiratory, social work, and even the parents. I think it's a time of really high stress and often uncertainty during rounds. Michael, your team found a different approach to rounding. Can you tell us about that?
Sure. Thanks for having me. Again, I'm Mike Pitt. I'm a pediatrician at the University of Minnesota, and I felt the pain points of rounding as a doctor, as you described, getting everybody together, trying to find the nurse, walking in the room and reading the handwriting of the nurse on the board and trying to decipher it and find the phone number and call them to join. And often if I walk into a room and the parents aren't there, I don't get to say to a 7-week-old, tell your mom what we talked about. We have to find them. So pediatric rounding is built in to be a team sport, but getting that entire team together is a problem. So I'd felt that pain point as a provider, but I had felt it as a loved one too. I'd been the family member sitting at the bedside, afraid to get a cup of coffee or go to the bathroom for fear of missing your one moment. You're in that room for 24 hours and you've got 5 minutes for the most important discussion of the day, and you're usually in the bathroom. Or the luxury that I even had that 24 hours to sit there. Many families can't be there and therefore miss out on that opportunity. So again, seeing both of those pain points, and then sitting in a haircut, great clips, and getting a text that says, your haircut turn is 5th. You have time to get coffee, thinking, gosh, why are we doing this in every arena? We give time transparency. We value people's time enough to tell them when will their package be there, when is it my turn for the table at the Olive Garden, yet we abandon that expectation in a literal, the only life or death situation in that whole list. And so it started with that frustration and then just said, well, what could we do about it? I met a colleague that's a computer programming engineer at the University of Minnesota and said, could you help me build the Great Clips app for healthcare? And that's how Q Rounds started.
So for Q Rounds, how does that work? So how is this mimicking your Great Clips experience?
So when the doctors are ready to create their rounding list, they log into Q Rounds. It's an app in the App Store, and it's integrated fully with the hospital's electronic health record. It pulls their patients in, suggests a rounding order based on the nurse assignments, based on the sickest patients, but you can drag and drop the patients into any order you like. This is taking on average 41 seconds. When the doctor hits share, that goes out to 3 places. It communicates to every nurse on the list that says, Dr. Pitt shared his rounding cue. You have 3 patients with him. Your first patient is at 9:45. Nurses are telling us for the first time in decades they're eating lunch again because they know when to expect the doctors. The second thing is it goes out to the electronic health record. So dietitians, care coordinators, social workers can all see that real-time rounding cue. But the game changer, the reason we built this, was the families. So the family gets a text message, just like if they've ever been to a hotel that says your room is ready, a text message that says, Dr. Pitt shared his cue, you're 4th to be seen, your estimated time is 9:15. And then if they click through, it shows a real-time countdown. I'm 4th, 3rd, 2nd, and gives families the opportunity to RSVP to join rounds remotely if they can't be there in person. So we've had just in the year and a half we've been in our NICU, we've had over 12,000 family members who couldn't have been present for rounds join remotely via Q rounds. One of the things that's exciting is the other guest on this podcast today is one of those parents. Ryan and his wife Anna had beautiful twins that were in the NICU for 6 months. And I'm excited to have him here to kind of tell that experience as well.
Ryan, that must have been a game changer for you and your family for the implementation of Q rounds. Tell us how impactful that has been for you.
Yeah, it is not an overstatement to say that Q rounds played a very critical role in not only providing a great experience in the NICU, which is a bad experience to begin with, but it drastically improved the experience. But I think it played a critical role in helping to save the life of James and Mary Grace, our twins, and get them home in a reasonable amount of time. But the thing about it is, in the moment when they were born, I've been very fortunate to not have to spend a lot of time in the NICU or in the hospital setting in general. So I didn't really know what I didn't know. Everything was new to me. And the first day that they were born, they were brought into their little nursery, and there was about a team of 12 doctors and nurses and RTs and neonatologists. Everybody was in the room, connecting them to monitors and giving them life-saving medications. And it was an incredibly high-stress situation. And during that, one of the providers came up to me and they said, they were giving me kind of the lowdown of everything that was going on and what to expect over the next 24 to 48 very critical hours. And during that, they asked me, they said, have you been signed up for Q rounds yet? And I said, no, I don't think so. She said, okay, let me take your number. I'll get you signed up. It'll just tell you when you're rounding every day. And my first thought was, what are rounds? I didn't know what rounds were, so I just was naive but willing to do anything I could. And so I gave him my number, and it took me maybe a day or two to kind of understand the significance of it. But once Anna got discharged from the postpartum room and we had to go home, well, now that became immediately much more significant to us, because now we're spending our nights at home while our kids are in the NICU. And so waking up every morning, the first thing we did every single day for 4 months was wait on that text to figure out when do we need to be there, to make sure that we were going to be there in person, or if we couldn't be in person, to be sure we RSVP'd for the phone call. And with the benefit of hindsight, having learned that that's not standard of care, that they don't do that at every hospital, I'll just say this, it baffles me that there is a NICU in particular, but hospitals more generally, that doesn't give patients and their families that level of access to be a part of the most important conversation of the day.
That's so very true. And oftentimes we have these rounds without the parents, and then we'll call the parents later and give them an update. And we all know things happen and we don't get to that right away, and then we're having to play catch up. And it's so important that parents are part of the care plan and are part of those discussions.
Yeah, it's not just a nice thing to do. I mean, it starts that. It is the human thing to do. It's the most important relationship and the most important discussion. But it's a best practice for a reason. You know, we know it leads to better outcomes when the families are there. We know it leads to better outcomes when the nurses are there. But it's a best practice that happens about 10% of the time because of all those coordination logistics. And so what I'm so proud of is, I kind of bristle at the word entrepreneur. I'm a pediatrician, and this is a problem we were solving, and a researcher. And what's been so exciting is to have all the stakeholders tell us that they think this was made for them. So the nurses are like, yeah, thanks for making Q rounds. It makes our lives better. The patients, it was a no-brainer. They're telling us they're not having to choose between quitting their job or being present for rounds every day. And you know this, bias is plays out when parents aren't able to be there. I'll have nurses say, oh yeah, this family's never been here before, and it creates this narrative, and then we turn Q-Rons on and they join rounds every single day because they're able to incorporate it with their other responsibilities. But what I was always worried about was that doctors and nurse practitioners and the lead providers would say, I don't want to do this. I don't want to click a button. I don't. And what they're telling us is it's giving them more meaning again because they're connecting with 7 additional families a day. It's making rounds shorter, which is counterintuitive, that having more families, but it actually, the efficiency adds up. And then to your point, now you're done with rounds and you've seen everybody, and people are telling us they're getting home faster because they're not tied up in that with all those loose ends.
I can see it being very efficient and actually saving time because you're not looking for all the other disciplines. You're not wasting time trying to call social work to say, hey, we're talking about that patient that you have a lot of information to provide. I have nutrition come to me and say, when you get to such and such baby, can you text me? I want to join rounds. But all of this would be eliminated.
Exactly.
And if I may just add to that, I think I'm in a very unique position to not only have been a part of the pilot of Q rounds at Children's Masonic, but when we were there, it was only deployed on the 4th floor NICU. And Masonic has 2 different NICUs. One's on the 4th floor, one's on the 11th floor. The 4th floor is for the most critical patients, whereas the 11th floor is the feeder grower floor, where babies are closer to going home. So we spent a majority of our time on the 4th floor because James and Mary Grace were in such critical condition. But once they got healthy enough to graduate to the 11th floor, we went up there, and everything told us that it should have been a better experience. We had our own private room for the first time. We could stay overnight for the first time. We had more space. I was working remotely from the hospital every single day. I had a table that I could use rather than just a folding chair on my lap. So everything about the experience should have been better. But the first day we got up there, we asked, okay, so when are we rounding today? We tried to get some information on it, and they said, oh, our rounding process is a little bit different than the 4th floor. They hadn't implemented Q rounds yet, and so they told us every provider does it differently. Sometimes it's the north side of the hallway. Sometimes it's the south side. Sometimes it's based on who's closest to going home. And so there was absolutely no way for us to plan around it. And that little difference, it might sound insignificant, but it made all the difference to us, because now we had to get there first thing in the morning, stay there all day, both of us, if we wanted to be a part of rounds. Otherwise, the way it would work is they would just call us after rounds and tell us the changes that they already made, rather than giving us an opportunity to provide our insight and input to advocate for our kids. And when you're a parent, any parent of a kid in the NICU will know this, you're not their primary care provider. It's the doctors and it's the nurses, and it has to be that way. But you still want to feel like you're doing everything that you can to be the parent that you hope to be for your children, and simply having that communication, being invited to participate in that conversation, makes all the difference in the world. So when that was taken away from us on the 11th floor, we actually asked to go back down to the 4th floor, knowing that it was a much more uncomfortable space. And that's how significant it was to us and our family.
That was an unexpected part of the pilot. We had multiple, we were doing it on the sicker floor to see if it could work here, it could work anywhere, with the complexities of kids on ECMO, etc. And Ryan and Anna's kids, Mary Grace and James, were born at 22 weeks. So they were, as early as you can be. And that's why they were there so long. But we had multiple families. The most common complaint in our NICU is shared rooms, and could we get in? So they're usually thrilled to get to this gorgeous 11th floor. And we had multiple families say, oh, can we go back? We'll rather have a shared room if we can still have Q rounds. That was part of what made them realize we needed to expand this to the whole hospital.
And especially when babies are getting close to discharge, that's when we need the family involvement more than ever.
Yeah.
So that would be awesome is it there now on the
It
11th
is, yes, yeah. Part I'm the most proud of is not a single day has gone by since the pilot that it has not been used by every doctor that could use it in the NICU. So that, it's a choice every day for the doctor to choose to make it. I spoke to one of the neonatologists yesterday, and she said she loves it. She goes, but it's a good thing she loves it because she would have to do it anyway because the families would never let her stop. It's become the standard.
Well, you have a lot of buy-in. If that's part of everyday workflow and nobody's complaining, then you've brought everybody's interest in this project.
Right.
As far as the time transparency, we all know during rounds things happen. We get stuck with a baby. Some other baby needs our attention. How does that change the workflow? As far as we might have to extend rounds. Do they get an update?
Yeah, so what's beautiful is it's not an appointment. It's not saying your doctor appointment today is at 10:15. It's saying your blank in line expected arrival is 10:15. Now, as soon as rounds start, those arrival times change. It's real-time updates. So if a patient takes longer, if somebody gets called to a code, they can pause rounds and everybody gets a message that says rounds have been paused. You'll get a text when it's been resumed. Parents in the NICU are the ones that understand that things come up, and sometimes their kids require more time and sometimes other kids. So we've not had a single complaint of, oh my gosh, you said you were going to be here then. That was a fear. What we have had is families that RSVP'd that they would be there in person, but now they have to get to the meeting and they can, get to work. They can pivot their RSVP to phone, and now they join. What happens is when I enter that room, when that family RSVPs, as I hit next, if the family's RSVP'd for a call, it says start call on my phone. When I press start call, my phone rings, the family's phone rings, and if necessary, an interpreter's on the line, and we're pulled together. So we've had many families pivot, or we are ahead of schedule, and they're like, oh no, we're in the parking lot. They would have just missed rounds. Like in the standard of care, they just miss rounds. But here they pivot to a call, their phone rings, and they're present. So and sometimes walk in the room mid call. So we've seen that as well.
You mentioned, Mike, about doing a pilot in your unit. What were the results that you found when you were using the Q round pilot?
So yeah, we did a 12-week pilot last year. 3 days into the pilot, they said you're not allowed to turn this off. We don't care what you find. But it was a research study. It was a grant-funded research study. So we obviously completed the study. We saw a tripling of nurse presence for the entirety of rounds. When nurses were present before, they were almost always joining after 2 minutes of rounds. If they made it, nobody was waiting for them. They were getting called, they were pulled in, and they were catching the end. On average, the nurses arrived 6 seconds before rounds started in the Q rounds period. So one was nurses were present earlier and more often. We more than doubled family presence. Since then, we went from 20% of the time families were present to 45 in the pilot, but we're now up to almost 80% of the time families are joining rounds via Q rounds. And then we saw no change in the study period in the length of rounds. It was the exact same average per patient. And now when you talk to the doctors now, they say, oh, I don't believe that. We're definitely faster. So we're actually repeating the study starting February 1st to regather data now that it's been used for a year and a half.
And if I can just add to that a little bit, just speaking from the anecdotal perspective, when we had access to Q rounds on the 4th floor, we did not miss rounds a single time, whether it was in person or via call. We were there every day. Certain conversations warranted having more people on the call, inviting families to the call, extended family members to the calls, but we didn't miss it a single day. And once we got to the 11th floor without it, we started missing it. Not because we wanted to, we just didn't know when rounds were going to be. And so the added element or the added benefit of participating in rounds every day is that it's going to make the conversation much easier. If you're only there once a week, you have to catch up on a whole week. Oh, when was this change made? When was that change made? Why are we doing it this way? Whereas if you're there every day, it makes each call that much easier because everyone's on the same page. And then when there is a transition to a new care team or a new neonatologist on call, now you have the ability to bring them up to speed a little bit on some of the things that you've noticed over the last few days. And it just creates a much more efficient process per round as opposed to a longer one once a week.
Ryan, I also remember you saying once that because you got the business meeting out of the way, like because you were present for the important meeting,
Yeah.
then if you met the providers in the afternoon, it was a chance to actually connect at a human level. Where you said to me once that like you felt because of Q rounds, they cared more about your kid, not just that they were that because they got to know you. I guess say more about that. I don't want to put words in your mouth, but that always stuck with me.
No, you're absolutely right. When you're in the same room with the same people every day, you're getting to know them. And like I said, sometimes those rounds are very quick. There's not always something drastic to change. And so you have a 30-second conversation about what's changed, but then you have a little bit of opportunity to say, ask them questions, ask the providers questions, learn where they're from. We found multiple mutual connections to friends and family and said, oh, so-and-so. And then you start to develop a rapport that way. You get to know the dietitians and the pharmacists who you would never otherwise get to see, and you can do the same thing with them. You can ask them questions about their life, and people have a vested interest in the overall care that's being provided because it is more personal. It becomes more human, and that's not a burden. Everybody enjoys that. If you have the ability to get to know your patients or the providers, depending on your perspective, it makes that whole process much more human, much more relatable. And we had the opportunity, thank God, to invite a lot of our care team, including neonatologists and RTs and RNs, to our twins' first birthday. And that's because we got to develop relationships with all of them. And so that was an amazing experience to be able to bring a lot of those people together after a year, which, just a not so fun stat that I read the night that James and Mary Grace were born is, I don't know if this is true, by the way, so don't fact check me. I just, when Anna was going into labor, I did what anybody does, and I just Googled what to expect with babies born at 22 weeks. And I'll never forget it. The first thing that I read was of babies born at 22 weeks, about 20% will survive the first year. And of that 20%, 80% will have severe lifelong complications. So it's an incredibly serious situation, obviously. But to be able to celebrate that first year birthday with that team that helped get us there was just a really special moment. And again, Q Rounds really facilitated those relationships being able to form.
Yeah, and hopefully you hear that's not just on Ryan and Anna's side, it's on our side. I'm a pediatric hospitalist. I'm not a neonatologist, but I kind of feel like I became one by proxy through this project. But I do think like most of us went into medicine because of a television show. Like my daughter, my 12-year-old's watching Grey's Anatomy. Hopefully this is a judgment-free zone that she's 12 and is on season 7. But but it was ER for me. And I always say like if ER showed an episode of somebody sitting on the phone with an insurance company for an hour trying to get prior off, or waiting for a lab result, nobody would have gone into medicine. And pretty quickly you go, wow, this isn't what it looked like on TV. But the relationships with families, that's the reason we did this. And we get pulled away from the bedside. We've had doctors say this is the first technology that actually makes them feel more connected to families. Usually it's pulling them away. And we're going to be doing studies on burnout and parental anxiety and all these things that as we start to implement this in institutions, looking at nurse engagement and turnover. And we looked at the years before complaints in the NICU. There were 13 formal escalated complaints. They were all about communication. 0 in the 18 months since it's been around. So we're really starting to see some of those communication angles as well.
I think that it will really help also, too, with collaboration amongst the team. Even nursing to be feeling like they're part of the decision-making, the care planning process for these babies. Because, like you said, they get there 6 seconds early because they're ready. They're ready to provide the data that the medical team needs in order to make these decisions because they're with the babies more than us, more than the doctors, so they know what's going on. And I think that allows them to feel like they have a voice. And also all of the other subspecialties that we bring in with us during rounds as well.
And I think you're right. And I think nurses are treated as middle people too much, meaning like, oh, I told the nurse so they can tell the family. And there's a telephone game that plays out there, and the trust gets, isn't shared among the team, and they find that they trust the nurse as their advocate, but not the doctor. And this shows us as a team, gets us in the room together, for those moments. So yeah, I think the number one question nurses are asked every day is when will the doctor be here? The number two question is, do you guys even talk to each other? And so like this is addressing both of those common challenges.
And the families, like Ryan says, he can see everybody coming together to be able to support him, his wife, and the babies.
Right.
Mike, in realms of what we're talking about with rounding, I know that you are passionate also about communication. Can you tell us a little bit more about that and how that affects with our rounding and our communicating with each other, our families?
Absolutely. I went into medicine as an English major. I knew that I'd learned the medicine, but I majored in English because I realized that you can be the smartest person in the world, but if you can't communicate effectively with patients, you're useless. Q rounds has made me realize if you can't communicate with them because you're not even with them, you don't even have the chance to be useless, in that sense. And you can do more harm than good. But I've been long passionate about realizing that we speak a different language in medicine. We forget that we learned that language. It's sad. We actually did a study at the State Fair in Minnesota. We asked over 200 adults, why do you think doctors and nurse practitioners use language that may confuse patients? And some of it was noble. They gave us the benefit of the doubt. We just forget that we didn't know what those words meant. But many people said to be manipulative, to drive the bill up so that they kept confused. The same thing that I feel when I go to a mechanic and I know that they are weaponizing pipes and fluids and belts, and my lack of understanding about that to get me to pay money, patients felt about the hospital, medical profession. And ultimately what we realized is we started doing these surveys at the fair. If your doctor said X, if your doctor said your tumor is progressing, what do you think that means? Is that good news or bad news? Well, progress in every arena is good. So over 1 in 5 adults thought that was good news if their tumor was progressing, or that an impressive X-ray was good news, or that they wanted that an unremarkable X-ray was bad news. We had somebody say, I read my CAT scan report and it said my testicles are unremarkable. And he said, I was devastated. He goes, I want remarkable testicles. And for years he said he was insecure until he went to medical school and realized that meant normal. So what we're doing is we've come up with, my colleague and I, Dr. Marissa Hendrickson and Jordan Marmette have published a lot of work on a framework of jargon, 7 categories of jargon, so that people can audit their language and realize that we're confusing patients. We even did just our job titles. We said if a dentist takes care of teeth, a pediatrician takes care of blank or specializes in blank, and had people fill in, hundreds of people fill in. Pediatrician got 89% correct, which is kind of sad, really. But the most common wrong answer, any guesses?
Feet.
Was feet, because they thought it was a podiatrist. Nephrologist, the kidney specialist, only 20% knew what a nephrologist was, and the most common wrong answer was a doctor of death. So people thought if we were referring them to a nephrologist, that group of people thought that we said they were dying in that sense. So just recognizing nobody knows what an intern is. An intern gets coffee for free at a temp job. But so why is it supposed to be a doctor in their mind? So we really have done a lot of work on that, including how we introduce ourselves. We gave people the choice. How would you want to hear the medical team introduce themselves? I'm Dr. Michael Pitt. We used all different names, but I'm Dr. Pitt. I'm Mike Pitt. I'll be your doctor. And 80% wanted to hear our first names. We're the only profession that hides our first name. It's pretty obnoxious, like patriarchal, and definitely keeping a disconnect. So 80% wanted to hear us say our first name, and the most preferred was, I'm Mike Pitt, I'll be your doctor. I'm Jill Beck, I'll be your nurse practitioner. Again, the difference of not just I'll be your kid's doctor. I thought was pretty powerful.
Those are really good tips to use just in common conversation with the parents. I know Ryan said the first couple of days he didn't even know what rounds was. And that's just such a commonplace thing in the NICU is rounds. So you can't assume that everybody knows what you're talking about when you're, first introducing them to the NICU, because it's so much information in such a short period of time in such a high stress environment. Ryan, do you agree?
I completely agree. And being a part of rounds every day, is the opportunity to learn the jargon. It's the opportunity to learn the different terms and the different specialists that are involved. I knew nothing about the NICU or really the hospitals in general prior to spending 6 months there with James and Mary Grace. And now I feel like, I can hold a real conversation with specialists in that field. Not to say I am a specialist, but I understand what the terms mean, and I understand what the different roles are and the significance of the different types of ventilators and what it means to be on a drip or what it means to have a TPN or all these different things I learned through being a part of those conversations. And you can only do that if you're there and able to participate.
And you had the people that were willing to explain it to you in detail and spend that time with you, which maybe you might not understand it during Q rounds, but we have another opportunity later in the day to touch base, and you can ask those questions then as well, too. So Mike and Ryan, we heard about the pilot study and the amazing results that you had with that. But what is next for Q rounds?
Yeah, it's been really exciting to, again, have a research project that was so successful that the university quickly had to say this needs to be available elsewhere. Let's help you spin this off as a company so that others can use this. We've expanded fully within our children's hospital. We're going elsewhere into our hospital system. We're doing our first group of adults starting in 2 weeks. That's a kind of a different setting entirely, obviously, because every kid has a parent who needs to be updated. Every family deserves this, but it's a cultural shift to bring this into the adult space. We, at the end of the year, just got confirmation that we'll be going into the Mayo Clinic for a pilot, so that's really exciting. And we've got several others lined up that are really close. So really the first thing is just getting this into other spaces. Our goal is that this eventually is free in every NICU in the country. And we've got several ways to do that, through philanthropy, but also through getting it into other units and waiving the cost for the NICUs. We really just feel like this needs to be the standard of care there. And we're seeing, again, accessibility. We're making access to rounds a right rather than a privilege for those that can be expected to be there. So that's kind of the mission behind this work. And then we've just got a bunch of cool features in the pipeline, ranging from the ability to bring consultants in. So not only can I have the family and the nurse getting those notifications, but I can also say the cardiologist, we want to know when they're going to be there. They can RSVP to join at the same time, before, after, and if it's the same time, they can join remotely, and the family can see us converse with the consultant. So we've got several grants under a review that are doing additional work with getting language equity and really streamlining bringing those interpreters on board as well. So lots of cool stuff.
So if anybody's interested in maybe trying to orchestrate a pilot program in their unit, how would they get in touch with you?
So you can email me at mike@q-rounds.com. And of course, you're waiting in queue, your position in queue. That's the play on the letter, but it's just the letter Q. And you can check out and book a demo right at qrounds.com. Happy to talk to anybody. We've got lots of creative ways to bring this into institutions and are really excited about what's coming up this year.
Thank you both for joining us today. I hope everybody is excited about this up and coming Q rounding tool, because I feel like this will be a game changer to make sure that we're including the really important factor of families and the humanistic side of the care that we do every day in the NICU. So thank you guys for joining us today. Make sure you never miss an episode of NANcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.